Electrolyte derangements in malnutrition and refeeding syndrome. Hypernatremia, hypokalemia, and refeeding syndrome are complications which can be encountered in managing malnourished patients. Hypernatremia. Hypernatremia is defined as a sodium serum level of greater than 150 millimoles per liter. Risk factors for hypernatremia include hot, dry weather and over-concentrated feeds. Hypernatremia is easier prevented than treated. The diagnosis of hypernatremia is mainly based on clinical suspicion and confirmed by blood results. The clinical features that are suggestive of hypernatremia include doughy texture on the skin, a scaphoid abdomen, fever, drowsiness that progresses to loss of consciousness, and seizures that are poorly responsive to anticonvulsants. The principles of treatment. Rehydrate slowly over 48 hours. Aim to reduce the serum sodium level by 12 millimoles in 24 hours. Nurse the child in a relatively humid, thermoneutral environment between 28 and 32 degrees Celsius. Take accurate daily weights. Target a positive water balance of 60 milliliters per kilogram per day. This should not be exceeded. Note well, fluid management is dependent on whether the child is conscious or unconscious and whether there is diarrhea or not. There is no consensus or robust evidence on which fluid to use in hypernatremia. The basic guiding principle is to rehydrate slowly. If the patient is conscious or semi-conscious with no diarrhea, give 10% dextrose or breast milk at 2.5 milliliters per kilogram per hour. Expressed breast milk is the best rehydrating fluid in this scenario. Do not give F75 at this stage and never use F100 or formula. Recheck the weight after 2 hours. If the weight is static or if the child loses weight, assess for environmental losses and try to prevent them. Increase the amount of intake to compensate for the ongoing weight loss. If there is accompanying diarrhea, use 1/5 of normal saline in 5% dextrose orally or by nasogastric tube at 2.5 milliliters per kilogram per hour. If the patient is unconscious, give intravenous fluids. That is 5% dextrose if there is no diarrhea and 1/5 normal saline if there is diarrhea. Once the sodium level has normalized and the child is awake and alert, start feeding with F75. Hypokalemia. Hypokalemia is a common problem in severely malnourished patients. The risk is even greater in the context of concomitant diarrhea and vomiting. In severe malnutrition, there is reductive adaptation, and at a cellular level, this manifests as a reduction in the number and activity of the sodium-potassium pumps, which leads to the accumulation of sodium inside the cells and leaking of potassium into the extracellular space and loss in urine. This results in an increase in the total body sodium and a decrease in plasma and total body potassium. The clinical symptoms of hypokalemia include weakness and hypotonia, reduced bowel sounds, and ileus. In severe hypokalemia, cardiac arrhythmias and respiratory failure from muscle paralysis can occur. The management of hypokalemia. The rapidity of potassium supplementation is dependent on the severity and the presence or absence of symptoms. If the patient is symptomatic, then rapid intravenous supplementation should be provided by giving an infusion of not more than 40 millimoles per liter of potassium concentration at a rate not to exceed 0.5 to 1 millimole per kilogram per hour. If available, continuous ECG monitoring would enable the detection of hypokalemia and rebound hyperkalemia during treatment. In asymptomatic patients with potassium levels less than 3 millimoles per liter, Oral therapy is preferred, and intravenous therapy is only reserved for those who cannot tolerate oral intake. Potassium chloride is the commonly available oral potassium supplement and tends to be quicker to correct hypokalemia as compared to potassium phosphate or citrate. Each 600 milligram tablet of potassium chloride has 8 millimoles of potassium. The initial pediatric dose is 2 millimoles per kilogram in divided doses. Each single dose should not exceed 1 millimole per kilogram or 40 millimoles, whichever is lower. Maintenance dose is 1 millimole per kg. Example: taking an 8 kilogram patient, for example, the initial oral dose is 16 millimoles per day, which translates to 2 potassium chloride tablets in divided doses. This can be prescribed as 1 potassium chloride 600 milligram, which is equivalent to 8 millimoles of potassium tablets twice a day. Maintenance is 8 millimoles per day, that is 1 600 milligram potassium chloride tablet daily. Monitor the serum potassium levels daily and stop replacement when normal. If hypokalemia is refractory to oral therapy, especially in the context of ongoing losses, consider intravenous therapy. Refeeding syndrome. Refeeding syndrome occurs in malnourished patients or patients who have fasted for more than a week who deteriorate shortly after a rapid increase in their food intake. The complications include acute weakness, floppiness or lethargy, delirium and neurological symptoms, acidosis, muscle necrosis, organ failure, commonly liver, cardiac or pancreatic failure, and sudden unexpected death. This occurs due to rapid consumption of key nutrients for metabolism. Serum electrolyte measurements should show hypophosphatemia, hypokalemia, and hypomagnesemia. Additional problems that the patient may develop also include refeeding diarrhea and refeeding edema. The treatment of refeeding syndrome. Reduce the diet to 50% of the recommended intake until all signs and symptoms disappear, then gradually increase. A child who deteriorates during the recovery phase or transition phase of treatment should be returned to the acute phase. A diet which is not cow milk based is high risk, and additional phosphorus should be given to prevent refeeding syndrome.